Once upon a time, half a lifetime from now, when I engage with the primary healthcare system, both my primary healthcare provider and I take care of each other's safety, feelings, and co-regulation. It means we share the hard parts, like money, time, and worry, instead of one person carrying all the stress. We make choices together, step by step, so we both feel safe and respected, even when things are scary or hard to understand. We use clear words, touch, and kindness to stay calm and work as a team. This kind of reciprocity of action is how I understand dignity of collective risk, a concept I hope will grant me a degree of relational autonomy, which the current care system actively seeks to remove from me. I am grateful for the ongoing support and collaboration, which is helping me understand how I can better recruit our environment to support me in my primary care journey. Through the practice of dignity of collective risk, I dream our environment grants me dignity by replacing my healthcare providers' abstract questions like, "What brings you in today?" or "How are you feeling?" with a framework that allows us to answer a different set of questions in context, rather than masking my way through this part of a frustrating primary healthcare interaction. I hope to no longer regularly reach this point in my interactions with primary healthcare. I think in pictures with a strong need to process information through tactile means to support my sensory localization, integration, and comprehension challenges. Through prior contractual agreement, our environment moderates a mutually consensual, reciprocal process which allows me to differentiate physical symptoms of my anxiety from my interoception sensations. I can't localize or even accurately describe them when I turn to the primary healthcare system seeking care. I dream of participating in a co-design process that allows me to interact with all providers in the primary healthcare system. With the support of third parties, I am finally able to grant meaningful consent rather than masking my way through some form of tacit acquiescence. This avoids the trauma I often currently experience because consent for my care was breached at some point when our environment overwhelms my functional capacity. To the outsider, it appears I drift off to a peaceful, tranquil sleep. In reality, I have started to fawn my way out of a panic attack. I am grateful for the ongoing collaboration, which has helped me repeatedly validate what I describe as mutual sensory environmental informed consent. This way of thinking of informed consent for healthcare is a process of establishing and maintaining shared, ongoing consent between patient, provider, and environment through synchronized sensory, tactile, and environmental feedback. It transforms informed consent from a one-time verbal event into a living ecological agreement, where communication, safety, and inclusion are co-regulated by human and environmental partners alike. Mutual sensory environmental informed consent ensures that my comprehension, regulation, and participation are always voluntarily maintained, even when my verbal, cognitive, and/or executive function falters. In this way, the environment becomes the steward of mutual consent. So safety and belonging are verified through what we can feel, see, and do together. The compromises my supporters and I reach with my primary healthcare providers mean I at last have consistent access to both dental care and family medicine in ways that tell me all my needs will be looked after, rather than only the most easily identified need that systemic bias identifies during the opening moments of my appointment. I am grateful for the ongoing opportunities to learn how I may contribute proactively to steward our environment, so we may collaborate to improve the quality of primary health care I can access. Holistic care free of strongly implied but unspoken chronic health conditions, often observed, which currently contribute to my sense of isolation from the primary health care I seek. While living in fear of a potentially underaddressed healthcare need, I can't comprehend, through practices which support dignity of collective risk and mutual sensory environmental informed consent for my primary care, I at last have access to an environment which grants me equity and a genuine, felt sense of belonging, where I have multiple, redundant ways of communicating with my primary care provider when they make observations about my well-being. I can confidently seek clarification through environmental dialogue in the moment, rather than becoming disoriented. Reciprocity invites me into their care, where previously underaddressed needs are evaluated in turn, and my nagging questions are finally answered. These answers, which took me about 10 years to arrive at, I arrived at through ongoing collaboration with my supporters and our allies. Support, hope, and encouragement I am forever grateful to have received. I'm privileged to keep receiving this support as I work with them to understand what segments of the population might benefit from this group of practices. What parts of the autistic population would this approach best support? What other groups of patients could experience increased quality of life as I dream mine improves